Hello, friends, and welcome to DTLC Season 13, Week 5. It is such a pleasure to have you with us once again, whether you're joining us live for the first time or you've faithfully been with us every Monday. Congratulations for making your health a priority. Your commitment to learning, asking the questions, and making small lifestyle changes is truly inspiring. We've now reached week 5, and I hope you're beginning to realize that managing diabetes is not about perfection. It's about making informed choices consistently. Every healthy meal, every walk, every blood sugar check, and every positive decision brings you one step closer to better health. Well, did you know that many diabetes medications work best when combined with healthy lifestyle habits? Medications alone cannot undo unhealthy eating patterns or physical inactivity. In fact, healthy eating, regular physical activity, good sleep, stress management, and taking medications correctly all work together to improve blood sugar control. Lifestyle and medication are partners, not competitors. Tonight's session is designed to help you get the best out of both. And today, we'll begin with a review of last week's topic, hyper and hypoglycemia. This will be led by Ms. Jalang'o, our diabetes care specialist. We'll then move on into our topic, medication management. Again, who else in a better position to present this than our diabetes care specialist, Mr. Jalang'o. She will help us or she will guide us on understanding diabetes medication, how they work, and how to use them safely and effectively. And then finally, we'll conclude with planning ideal meals and grocery shopping. And this will be presented by none other but our nutritionists in the house, Baline Mali, and then assisted by Dr. Alice Ojwang. So sit back, have your notebook ready, enjoy the session, and we really encourage you to ask your questions, type them in the chat, and then we'll answer as many as we can during the session as we move on. Once again, thank you for joining us. Before we dive into the main topics this evening, we'll first have a review of last week's topic, hyper and hypoglycemia. And to guide us through, it's my great pleasure to invite Ms. Jalang'o. Ms. Jalang'o, we are ready.
Yeah, thank you very much, Lydia. Good evening, everyone, and I'm excited to be here yet again on DTLC 13. And we'll kick off with a reminder of hyperglycemia and hypoglycemia. If you can remember very well, hypoglycemia are the extremes of blood glucose management. So we want to maintain our blood glucose levels within the various parameters depending on the hours after eating. But essentially, we would want after 3 months that when your HbA1c is done, that you have a true blood glucose of 7 millimoles. So time being within the range is important. You don't want to be either too high or too low or having excursions that then give you a false 7. So we said very important to the HbA1c is the monitoring that you do at home. And if you can afford, then the continuous glucose meter, continuous glucose monitoring system. Now, hyper is high blood sugar, and it can lead to very severe complications if we don't manage it. And it is often the cause of the complications the long-term complications that we get with the diabetes. So it is important that it is managed and managed in good time. Sorry about that. Then The other thing that is very, very important in regards to hyperglycemia is to know the things that cause them. So ensure that your medicine is working and that the medicine is also taken within the required time. Don't take your medicine late. Do not titrate your medicine. Do not miss your medicine, because if you do, then you will have a problem with your blood glucose going high. Watch out for times of stress when certain parameters around your life can lead you to have high blood glucose. So having a machine is always important and it's handy. When we are able to ward off hyperglycemia, then the chances of having the long-term complication of diabetes is then reduced. Then we went to the other side of the other extreme. When you're doing too well sometimes, or certain times, you may take more medicine, you may not eat enough, you may do a little more exercise, or you may take your medicine and then eat late. Then you are at risk of low blood glucose, what we call hypoglycemia. And in last week, you remember we talked how to manage hypoglycemia, the rule of 15. 15 milligrams of carbohydrate, a simple sugar, wait 15 minutes, recheck your blood glucose. If it has not gone above 3.9, then you will need to repeat and wait. And then once it goes up, then you take some snack with some protein. Okay, so some carbohydrate with some protein so that it doesn't come back. All in all, to manage both conditions, to keep them in balance, remember lifestyle is key. Lifestyle. So do not forget your lifestyle. So balance your diet, especially watch on the carbs. Your exercise is important. Your medication has to be taken as prescribed, and you check your blood glucose. And of course, remember the other lifestyle management parameters, your sleep, your stress management, and then managing stress. So at the end of the day, to ward off hypoglycemia and hyperglycemia, the most important thing is to be able to manage your blood glucose well through your lifestyle intervention. And if you're using medication, your medicine. So diabetes self-management is not a battle with blood glucose. It's negotiating peace between hypoglycemia and hyperglycemia. And you have what you need as you go through this program. So thank you, and I'll hand over back to Lydia. Lydia, take over.
All right. Well, thank you so much for the review. Such a wonderful reminder. So, Alice, we are ready with to go through our blood sugar review, as usual.
Is there anybody with a question though from last time? At least a question before we go on to the session. We have anybody? Yes. Is there a question in the group? No. Okay. No question. Okay, good. Well, that means you're understanding this. Okay. And also last time I encouraged everybody who has not ever taken their blood sugar to go and get their blood sugar checked and HbA1c checked. So I haven't got any feedback, so I'm not sure who did, but it would be nice if somebody did and at least shared in the group. So now we'll quickly look at, talk to one of our clients, Catherine. She was in was she season 10?
11.
Season 11, okay? And I just wanted to encourage, because from the numbers we have in the group, okay? Yeah, Lydia, how many people do we have in the group? We have 84 participants. And according to our data, 74 participants are living with diabetes in the group. So then I'm not seeing your measurements. I'm not seeing your questions. Are you lost? Are you going well? We really would like you to be progressing. So let me just share Catherine's experience, and then you can meet her and she can tell us what is it that she benefited, just to encourage you. And please remember, as much as this is a diabetes session, it's DTLC 13 is diabetes. This still applies to all of us. It applies to people who are not living with diabetes. So this knowledge is for you to prevent. So I'm going to share my slide. And okay, wait a minute. Yes. I'm just going to share my slide. Yes. So can you see that very well, Lydia? Full screen?
Yes.
Yes. Okay. Don't miss this. Oh, sorry. Full screen mode. Okay. So this is when Catherine started. This is, and I hope her hand is up so I can trace her and put her on camera when I finish with this. So she started, she was on medication for diabetes, but you can see when she was measuring her sugar, the way we told you, you can measure and you can be able to interpret. So she did this herself after the education, okay? So this were her sugars. You can see week 1, okay? Red, red, red. Week 2, everything. Fasting, you see fastings over 10. And this is not even high. This is actually very high, you know. When you have fastings of 10, of 9, all these are very, very high. Yeah. So she had very high blood sugars. Okay. Fastings of 10, 9, very, very high. So you can see she had all this was orange, you know, high and very high. Yeah. Then let's see. Week 3, how is she doing? Still high, but you can see she's starting to get good blood sugars. She's starting to get normal blood sugars. Even her fastings are getting better from high to raised, right? And so, see, so she still has some challenges here, you know. So she's getting a few highs, but let's keep watching. That is week 4, but you can see we've come from very red and orange to we have very good ones. So week 4 and 5, she still has challenges with her fasting. And this is the one that was giving her problems. And fastings can also be related to the dawn phenomenon, you know, what is happening, your stress levels. But we kept working on it. And so she's getting better. She's better. Out of this, 4 out of 24. Okay, this sheet is about 25. So 4 out of 25. You know, so that's like 75%, very good blood sugars. Okay. And so week 7, you can see we're just in week 5. For her at week 7, this is what we were seeing. Yeah. So this is just telling you that if you make an effort, you will get there. And we are here to support you. And you can also see, even though week 8, she could still eat some chips and cabbages. You know, she knew her portions, but if you look at the you can just see the differences. I have a food chart, but we don't have time for that. But when we started, the carbohydrate portions, like all of us, you get, all of us, carbohydrate portions are always crazy. So she has done very well. Of course, we have challenges sometimes, but you can see mostly her sugars are good. She's had problems with fasting, but now I think she's got it. Now her fastings are at 5 and she's doing well. So where's Miss Catherine so that she can tell us what it is that. Yes. Okay. So Catherine, if you're there, you can unmute. So tell us, what did you start doing? What did you stop doing when you joined the program? Thank you for being there, Mama.
I really had to observe my portioning of food, you know, because at first, well, let me start by saying that I didn't really know how to balance I didn't know what to eat at any particular time. But now, through the lesson, I was able now to continue adjusting myself day by day. And when I eat something, I am testing whether that whatever I have eaten is good.
Move next to your phone so we can hear you better. Thank you. Yeah. Thank you, Mami.
So now
Better.
that's why you find that. Okay. That's why you find now that I was trying. They were fluctuating from time to time because I was now trying to see what my body will be able to work with, And the moment I noticed what I should eat and what I should not eat, I was a very happy person. Because now I would be able to know, even by the look of what what my body doesn't like, I could just know this one will give me a rise immediately. And I would just stop. So now what I can say about DTLC, I can only say that I have learned a lot from DTLC, and they have sustained me because I could not have lived. I don't know. I thought probably diabetes is there to stay with me forever. I didn't know that I could even, it could come down. I didn't know that. But now I am so confident. I'm listening to DTLC all the time because I know out of all the things they will say, I will learn something. And that I'll add it now to my knowledge.
Yeah. Thank you so much. Yeah, so let me also just show your plates. And this is, of course, after you did. I don't know why we didn't put the before carbohydrate intelligence because they were they were deadly. But yeah, you can see how we learned how to eat healthy, lots of vegetables, carbohydrates, This is after carbohydrate intelligence, But you can see week 1. Look at that, double carbs, okay? Yeah, look at how this is fruits and sweet potatoes and milk, 3 carbs in 1 meal. Thank you so much. Then you have porridge, and then we have banana, this is week 2, So we have potatoes, we have, you can see what was happening here with her food. Good, very large portion of oats, Yeah, rice with beans. So now let's see after she changed. Okay, you can see, that was till now week 5. Look at week 5. Look at the change. Okay, so if you change how you eat, something changes. Something changes. Look, vegetables, she is eating a variety of vegetables. Before that, it was cabbage. I remember we used to have a fight all the time. And at some point I confiscated cabbages, if not literally, but I told everybody no cabbage. We didn't want to see cabbages in the group so that we can eat other vegetables, Yeah, so thank you so much, Mami. Thank you for sharing your story. And we appreciate you very much. So this is just to encourage everybody. Thank you. Thank you very much. Yeah. Did you have a last word? Oh, she's late. Okay, very good. Yeah. So thank you. So this is just an example of what you can do. And you see, we are empowering you, and we are here to reinforce that empowerment by getting your blood sugars, helping you analyze, walking with you through the journey, and then the sky is the limit. Yes. So thank you so much, Catherine, and thank you, everybody. Over to you, Lydia.
Well, thank you so much, Dr. Ojwang, for that insightful review. And thank you to your participant for courageously sharing their experience with us. Surely, it's a powerful reminder that consistent effort truly, truly pays off. So there was a question I saw in the chat. What do you mean when you say fastings?
First of all, I think Dr. Jalang'o also had a question for Catherine, eh?
All
Yeah,
right.
I forgot. So what do you mean when we say fasting? So when we say fasting, what we are actually talking about is fasting when the patient wakes up in the morning before they eat anything else. So that is a fasting blood sugar. So what you saw is a fasting when they wake up in the morning before they eat anything. Yeah.
At least 6 hours without any food.
Yeah. Okay. You had a question for Mommy, Dr. Jalang'o.
Yes.
Before you go to your session.
Catherine,
Yes.
I remember working with you and I really loved your enthusiasm, especially with walking. You really loved walking, you know? And I just wanted to ask you, do you know your medicines? What they do and what are the side effects? Do you know the medicines that you take? Yeah.
Oh, yeah. I do my medicine. Yeah, because I changed the medicine.
There's
Can
something
you
with
hear
the
me?
network. Yes, we're
Yes,
hearing you
we
now.
can hear
You
you.
were
I think
lost
she
for a
put on the
moment.
camera so that you can be better. So continue. Sorry.
My medication, I changed from metformin, and one of the doctors helped me, one of you helped me out, and because I was taking a metformin twice a day, and but it reached a stage where now we had to change medication.
Yes.
And we went to proof of it. And at this time, I was taking one in the morning. We struggled a bit to change the timing until we reached a conclusion. Dr. Jalang'o, you're the one who told me that the timing that is fitting me is in the morning. So from the time I started taking glucophage, 500 mg in the morning up to today, that is what I do all the time. Yes, yes.
Okay. So how does glucophage work?
Glucophage is fair. It's very good because I don't have, especially these days, I don't even get those dawn phenomenon. When I wake up, I wake up very fresh. It's okay, you know, struggle that bit with that phenomenon in the morning, and my are quite high even when I wake up in. But I realized that after some time, if I could do my fasting not early in the morning, maybe a little bit later, around 9:30, 10, my sugar were down. They were down up to 6 or even less. So I came to that then I should not take my sugars quite early. I should not even have breakfast so early to allow my body to calm down. And that's, I can say that the glucophage is helping me a lot. Yes.
Thank you, Catherine.
Yes. Yes. And I look forward to a time when I will even do away with it. So I'm still working.
Yeah, good. That's a good commitment, Catherine. Just keep the progress and the focus. It will eventually pay off.
Okay.
Yeah.
I'm happy. Yes. But I love DTLC. I don't know what I would have done if it was not DTLC. Because I had given I had said, oh, because I hear people say diabetes is for life. Then I thought, then I have to live with it until my dying day. But now what I believe is that I will not even die out of diabetes. Perhaps those who are soon or parenting that before men, but not diabetes. And I'm also happy because my family members support me a lot. It's such a group as a family to show every day what we eat. And that is also encouraging me. And I was even telling them when they take a lot of carbs, and I could tell them, no, this is all carbs. I became their teacher, to tell them what to eat and not what to eat. So they have also encouraged me to a certain level until at one time they were telling me, hey, that is too much, mom.
Okay, thank you so much, Catherine. Yeah, so thank you also for reminding us it's not just medication, but also the lifestyle that drives a lot of things. And I'm really glad for the progress that you have made and will continue to make.
Yes.
Yeah. Yeah. Somebody had their hand up. Samsung SM.
Yeah, my name is Ogola. Hello.
Yes, we're hearing you.
I'm amazed by Catherine's change. She, some of us are taking this. Is it metformin?
Metformin, yes, yes.
But it is really, in a way, it affects us on and off. So when she says that she changed to another drug, I'd really like to know which drug it is.
It's actually metformin, but the slow release, metformin XR.
Did she change the schedules of taking? Like, did she change? Like, we are taking it twice a day. What she's taking, has she changed how many times she's taking it a day?
Yes, once. The XR formulation is extended release, so you only take it once a day. And then the other intricate thing with metformin, don't take it before meals, don't take it after meals. You take it in the middle of the meal.
Then that's the mistake I've been making.
Otherwise, you'll have very bad stomach upset.
Not even stomach upset. Yeah, some very bad feeling in the discomfort all day.
Yeah, gassiness. Gassiness.
Yes.
Yeah.
Bad medicinal feeling, but we were not taught these things. We are learning them here, yet we have been meeting high-level professionals.
Thank you that you came here.
Thank
you for making this investment. Yeah, thank you for making this investment.
It only goes, that feeling only goes off when you do a 1 hour walk and you sweat out. So I'd really like this in written form, because my doctor told me that my physician, I can change to another brand.
Yeah.
But it would still be 500 over 1,000.
No, that means you are using a combination. You're
I'm
not
using
metformin. You're not using metformin alone.
I'm using, let me tell you what I'm using. I'm using glutamate, sitagliptin, something 50 mg, and metformin hydrochloride.
Yeah. That's a combination of sitagliptin and metformin. So you take it with your food. You will feel better. Yeah, take it with food. Yeah. Okay.
You take it after you have taken food a bit in between.
with food when you're eating.
Okay, but he's going ahead. Sorry to interrupt. He's going ahead. I think the session we are having now is medication management. And so
we'll
your questions
that.
on medication will be answered. And also, you don't just change medication because you had somebody change. This is a process that you also work together with your doctor. So we empower you and then you learn, you change your diet, then you have a discussion with your doctor. So most of the medication will be talked here. So over to you, Dr. Jalang'o. Yeah.
Thank you very much. Let me share my screen.
Yes, as she does that, please note we've moved on to our topic, medication management.
Pay attention because there's an assignment after this.
Yes, there is an assignment, that's true. So today we are going to discuss medicine. Not everyone uses medicine when they have diabetes, but some people will need medicine. So today I'm going to be taking you through the different medications we use for diabetes, and that will be our agenda for today, the introduction, the goals, then the underlying issue, what are the medicine categories, and certain tips and takeaways, and then your challenge for the week. Now, I want to thank everyone who did their homework. There was some work that was given, and many of you filled in that survey, and I was able to see what medicine you're using, and secondly, to put it into a sheet which I will be sharing in the group. So after this, you will be able then to know where do you lie in terms of the medication you take, how does it work, what are the effects and side effects. Now, as an introduction, we learned that diabetes is a condition which affects how we process food, okay? And we are also learning that lifestyle is very, very important to taking care of diabetes. However, some people may need medication to control their blood sugar levels and to prevent complications. Now, type 1 diabetes, they don't produce any insulin, so they often have to be given insulin. Type 2 diabetes, it depends on when you're diagnosed. If you're found early, you may not need medication, but if it's a bit advanced, then you need medication. Why do we manage diabetes? One, we want to restore the metabolic balance. You see, metabolism is about breakdown and buildup of your nutrients. Insulin controls this, not just glucose alone, but all your nutrients, even your electrolytes and your ions. Now, when insulin is not there, the body is out of balance. So the first thing we do by giving you medication or lifestyle management is to restore metabolic balance. Then we optimize your quality of life so that you feel well and are able to do your daily activities. Then we also want to prevent short-term and long-term complications. Short-term complications like hyper, and then we don't want those complications in the long run that affect your eyes, your teeth, your kidneys, your liver, your sexual function, and even your feet. Then we realize also that diabetes often does not come alone. It comes with other conditions. This is what we call comorbidities. These are things such as arthritis. Sometimes you have hypertension and other illnesses that are often associated with diabetes. These need to be managed and are part of your management goals, because if we don't manage them, then you won't have a good quality of life. Now, diabetes, the causes that make your blood glucose go high, and especially when you have type 2 diabetes, are a number of factors that range from issues in the intestine, where you have decreased incretin, and there are drugs which work there. And then you have issues in the liver, okay? So issues in the liver, in the pancreas, where you have problems with insulin production, or when the body is resistant to insulin, it overworks your pancreas. You have issues in the liver. When you have insulin resistance, the liver releases a lot more glucose very fast than it should. then you also have issues with neurotransmitters in the brain. You have issues in your muscles and even issues in the kidney. So diabetes is very complex, and that is why you find it is a very, very complex disease that many years, and we have not come to a treatment that actually sorts all those things up. Now, when we are taking medicine, one, we are looking at actually optimizing your blood sugar. We want to bring the blood sugar down to between 4 to 10, or even better, between 4 to 8 if you can. Then we want to prevent complications, acute and long term. So you don't want hypo, hyper, and at the same time, you want after several years, somebody does not end up with diabetes related complications, because they make your life difficult and they cost a lot. So eventually, we are improving your overall health and quality of life. Now, what are the categories? You have the injectables. One is insulin, that is used for all type 1 diabetes and some type 2 diabetes. Then we have the non-insulin injections, that we now have, and this can be used in both type 1 and type 2 diabetes. Then you have the oral medications that are very common. These are your tablets that you often take or swallow that are commonly used for type 2 diabetes. And then, of course, the other conditions that you may have, the comorbidities, then we have commonly the common medications that we use. Now, insulin. When we look at insulin, we have fast-acting insulin, rapid-acting insulin. That is your aspart, your lispro, and your glulisin. Then you have the regular insulin, what many people call soluble insulin. Then you have the intermediate acting, the NPH. And then you have the long acting, like Detimir. I think I saw somebody who has got Detimir and Levemir. Levemir is this. It has an action profile like the red line. Now, if you're using a Mixtard is a combination of regular insulin and NPH. So you see why it has that fast-acting bit, and then it has the NPH, which goes up to 16 to 18 hours. That's why Mixtard often you need to take twice a day. Then if you're using, I saw somebody who wrote a Lispro insulin. Now, if you're using Lispro, often you will use it with the basal insulin like Detimir or Levemir or Glargine, okay? Because look at how fast it acts. If you use it alone and then the next meal is somewhere here, then there's a gap. But when you use it together with this, then the gap is covered. So different insulin act differently, but the common thing about insulin is they all make blood sugar go low. So the common side effect of insulin is hypoglycemia. So insulins like Mixtard need to be taken half an hour before, because look at its action profile. It takes some time to act, at least half an hour before it gets into the system. So you need to take it before you eat, so that by the time that the food is going in, it finds the insulin already in the system. Fast-acting insulins that act within 15 minutes can be taken just before you eat, okay? So your Lispro insulin can be taken just before you eat. Now, how do we deliver insulin? You can inject insulin using syringes and pen, and also you can use what do you call them? The insulin pens. It's easier to carry the insulin pen and more convenient than when you use this, okay? But this then has more cost because of the convenience as opposed to this. So most important is just to know how to inject, how to measure, which when it is prescribed, you need to be taught, and then you take your insulin at the prescribed doses, and ensuring that you do not take too little or too much. Then the next form of insulin delivery is the insulin pump. You can have a pump alone, okay, whereby the pump delivers insulin through an infusion set. And this, you still have to do a lot of things if you have a pump that only gives insulin. But then we have what is called the closed loop system. We have advanced pumps that work with a continuous glucose monitor. They communicate. So this pump is like an artificial, combined with the CGMS, they act like an artificial pancreas. So the pump is able to respond to the changes in glucose measurements coming in from the monitor, and therefore it adjusts your insulin appropriately with very little intervention from yourself. Now, I would like us to pause for an activity. Write in the group whether you have ever acted to a diabetes medication. List the name of the drug and what happened. If you have ever reacted to any diabetes drug, list the name of the drug and what happened. So the other thing, always remember that you must read medication labels. Now, you write in the chat why it is important to read medication labels. So Lydia, you'll keep watching the chat as we go on. So remember that, please. If you have ever reacted to a diabetes medication, please list the name of the drug and what happened. And then if not, you write in the chat why it is important to read the medication labels. Now, we go to the drugs, the other drugs, especially the ones that are more or less used for type 2s. And the first one is the biguanide, and the common one we have in Kenya is metformin. It comes in many forms. So if you have glucophage, metformin, biophage, anything you hear phage, remember it is a biguanide. Commonly, they cause nausea, diarrhea, stomach pain, and in the worst case scenario, lactic acidosis. The former drug in this group called fenformin is no longer used because it used to cause lactic acidosis, and that can kill. So if you have any discomfort with this drug, it's always good to inform your healthcare professional. The other group of drug is the sulfonylureas, okay? Now, I saw people with the Amaryl, glimepiride. I saw some glimepiride, Downil, diamicron, glibenclamide, okay? Those are sulfonylureas. They stimulate insulin release from the pancreas. All these drugs cause hypoglycemia. They can cause hypoglycemia. Then because they lower blood glucose, any drug that lowers blood glucose, there is a chance that it can cause weight gain, including even insulin, okay? Then nausea and also skin rash. So always remember sulfonylureas, Downil, diamicron, Noglu, glibenclamide, glipizide, they can cause hypo. Then meglitinides, the common one in our setup is repaglanide. Now, they also stimulate insulin release, but from a different receptor. The receptor is not the same like the one for sulfonylurea. That is why we put them in another group. And then they are only taken before food. So we have repaglanide, which is in the country. Nateglanide is not here. And they also can cause hypoglycemia, weight gain, headaches, and joint pain. Okay? Then the other one, which is here but not very commonly used, is pioglitazone. It improves insulin sensitivity in muscles and fat cells. This group of drugs has been associated with some cancers, and that's why they're not commonly used, and also with bone fractures. But they can also cause weight gain, edema, okay, peripheral edema, and in some cases even heart failure. So they are not very commonly used. Now, in some people who can't tolerate metformin, we can give you alpha glucosidase inhibitor, which is acarbose. What it does, it slows carbohydrate absorption in the intestine. So the big problem with it is when you slow carbohydrate absorption in the intestine, you make the carbohydrate sit and ferment. So flatulence is a big problem. Many people can't tolerate this drug. Only few people can use it. So flatulence, you get diarrhea and sometimes even abdominal pain. Then the other drugs are the DPP4 inhibitors, which are the relatively new drugs in our setup. I had somebody talking about sitagliptin. I saw also in the list linagliptin, okay? So these drugs enhance incretin hormones in the gut. What this does, it reduces gastric empty, gives you a feeling of satiety, but it also enhances insulin action. So your insulin works better when you take incretin hormones. When you enhance incretin, they are not hormones. DPP4 inhibitors are not hormones. They enhance incretin hormones. Now, the side effects are upper respiratory infections, headaches, and they sometimes inflame the pancreas, causing pancreatitis. Then the next set of drugs are drugs that behave like some peptides in the gut, what are called the GLP-1 hormones. They also enhance insulin secretion and therefore help reduce blood sugar levels. These are the liraglutide, zenatide, semaglutide, and dulaglutide. Now, these are the drugs you've seen people are really misusing because the major side, the other effect they have is apart from lowering blood glucose, they lower weight. Okay, so they are really being used too much. Okay, they are the Ozempics, the Ozempic, Wegovy, those drugs. So they can cause nausea, vomiting, diarrhea, constipation, headache, dizziness, injection site reactions, and pancreatitis. And now in some countries, we are seeing the long-term effects, the Ozempic face or the Ozempic feet. And then you are also now having other severe complications coming up like kidney failure, blindness. So be very careful with these drugs. People are even selling them in beauty parlors. They're really being misused, and they're not very good drugs. If are misused, they have very serious side effects. They should only be used in a controlled way and on prescription. Please don't be tempted to use them anyhow. Then the last group is the SGLT2 inhibitors. These ones, they prevent glucose reabsorption in the kidney. So what happens when they prevent glucose reabsorption, you secrete the glucose, and therefore the glucose in the blood goes down. So they lower blood glucose by enhancing secretion in urine. Now, their side effects are related to that. I saw somebody who has empagliflozin, that's empagliflozin, and then somebody else was on Forxiga. Forxiga is also an SGLT2 inhibitor. So common complications are urinary tract infection, yeast infection, and they can also cause dehydration. So that's about it. So when you look at the diabetes medications that I've talked about, you will see they are targeting certain organs, the same organs that are related to causing hyperglycemia. So sometimes you can take a combination, sometimes you can take one, depending on you as a patient and how you appear in terms of your profile to your healthcare professional. And then, of course, remember the other thing that determines is the cost. Some of them are costly, some of them are effective, but one thing some of them are not too costly. But one thing I would like to say is that the effect does not really depend on the cost. Some of the simple medications that we have had over time, when you use them well, you still have very good outcomes. So don't stretch yourself to buy new molecules. The simple drugs, when used effectively, combining with your lifestyle and taken appropriately, will still give you very, very good results. Now, there are other medications, junior aspirin, clopidogrel. These two reduce the stickiness in blood, you see, and prevent heart attack and stroke. Initially, we used to give them routinely, but we nowadays look at your profile before we give them. Then, of course, if you have hypertension, you'll have the antihypertensives. So I saw some people with calcium channel blockers and beta blockers, you know, the concours. There was somebody on concours, I think that's a beta blocker. Then there are the cholesterol lowering agents, atorvastatin, rosuvastatin. Those, if you have high cholesterol, then those help with that. But also remember, sometimes you're started on these drugs and lifestyle could help. We've seen a number of people coming in the program with high cholesterol as they take up the different initiatives in terms of changing their meal planning, exercising, reducing stress. We've seen cholesterol lower. Okay. Then, of course, you may need vaccinations against flu or pneumonia. And then the other big contentious issue, that's why I've put those 2 stars, is supplements. Please don't just take supplements anyhow. Some of them may react with the medication you are taking. And then the other thing also where we have to be very careful is herbal therapies. Don't take herbal therapies when hiding. You should be able to discuss them with your care professionals, and so that we avoid possible medical interactions. Now, at this point, I saw somebody who wrote rosemary injection. I don't know why they're taking it, but anyway, I did some research around it. You can use rosemary injection, one, to stimulate or hair growth or reduce hair loss. The other thing that rosemary has been found to do is, and this I'm talking research, this is not just anyhow. I looked into PubMed and I found some papers on rosemary injection. The other thing that it has been found to do is to raise glutathione. So some people use it to enhance liver function. And then lastly, the other thing about rosemary is that it reduces inflammation. But rosemary is highly toxic and you cannot just take it anyhow, especially the injectable. And especially the oil, when you're using the oil, taking it orally is also very, very dangerous in case you overdose. So please don't use those things unless it is prescribed and you know why you're using it and how much. Now, some tips. You need to take your medicine as prescribed. You may need reminder boxes. You can put alarms. Now, the reminder boxes are very good. They're up here, you see? So you can put your drugs. You can have 2, 3 of these. They are now available. I see them at Carrefour. If you can get these things, arrange your medicines for the week in there. Because if you forget, you will see the medicine still there. So this is a good way of helping you remember. Then you read your medication leaflets. Have we gotten any responses why we should read medication leaflets? Lydia, can you read them out?
Yes, we have quite a number. To know the type of drug, to know the expiry dates, to know warnings, interaction with
Good.
medications, side effects.
Yes.
And then we have to reduce the chances of allergens, reaction, recommendation, categories. And then I'm looking for one that is different. Direction of use. Yes.
Excellent. Yeah, I think those are very good, very, very good responses. Yes, your medicines, you need to read the medication leaflets because sometimes we tell you the common things and you may get the rare reaction. So very, very important. Your drugs may react even with certain foods that you're eating. So it's important to know which ones, okay? Like if you're taking metformin, it reduces the absorption of the B vitamins, you see? So if you don't know that, you see, so and you're taking those and you're not getting the desired effect, then you say, so it's important to read your medication leaflets. Then the other thing, do not titrate your doses. What do I mean by titrating your dosages? Sometimes you are short on money or the clinic clinic visit is maybe 2 weeks away and the medication is finishing. So you decide to reduce the dosages to ensure that it reaches the time of the clinic or to save yourself on money. What happens is you go out of control and then you know what happens, then your sugars go high. Do not share your medication and also keep your medication in a safe place away from pilferage. And then the other thing is you want to keep it if you have grandchildren, you have children who may be young or grandchildren, they can take your medicine and it can harm them. Then maintain a healthy lifestyle. I can never, ever emphasize this enough. Monitor your blood glucose level and your other numbers, Be aware of the medication, name side effects and effects. Store medicine. Safely carry drugs when you're away from home. When you're going out, please remember to carry your medicine. Stay informed and communicate. So follow up with your care provider is extremely important. So as a final takeaway, take charge. Your medication is your responsibility. Medication is an important component of diabetes management for a vast majority. However, lifestyle modification is key. Regular medication adjustments may be necessary. Therefore, I emphasize again, follow up. Know your numbers. Know your medication. Know what to do in case of an adverse event. Hypers, sick days. We always say when you are sick and you're not vomiting, take your medicine and take preferably a liquid diet. Keep hydrated, okay? Because when you're sick, more often than not, your blood sugar tends to rise. Now, if you are vomiting, please, you have to run quickly to the hospital because that can be dangerous, okay? Then anytime you get a side effect or an adverse effect, you need to alert your care providers quickly as an emergency because something might start small and can just go out of control. Then remember, medicine is the support act. Lifestyle is the main performance. You are doing lifestyle 24/7. Medicine you are taking maybe 3 times a day, 2 times a day, once a day. But you are sleeping at the right time, exercising, eating. It's a 24-hour thing. But medicine is just the support act. So remember, lifestyle is your main performance. Medicine, the support act. So thank you very much. Now, I will share in the group the list. I'll give to Lydia to share in the group the list of your drugs. I have categorized your drugs. Anybody who sent their drugs on the list, I've categorized your drug with the group it is in. Now, based on what we have learned today, kindly you will do this homework. Name your medication, the type, how it works, the dose, and the side effects. Read your labels. That is your challenge for the week. Thank you very much, and over to you, Lydia.
Well, thank you so much, Dr. Jalang'o. That was quite informative. I know we have questions. We have decided to leave the rest of the time to take in questions regarding medication. Feel free to unmute, raise your hand. We're in good hands. Dr. Jalang'o is here to guide us. So feel free. So we actually have one in the group. Says, kindly explain the importance of vitamin B12 injection.
Yeah. Okay, if you have a deficiency of vitamin B12, then you get neuropathy. You get neuropathy. And it's common in people who have diabetes, and especially if you're using metformin. So if it is low, it is important then that is supplemented. And there you can either take it as tablet, but if it is very severe, then you will be given injection. Alice, comment on that as well, yeah.
Sorry, you're muted.
We can't hear you, Alice. Unmute, yeah.
Thank you there. So also it is also for vegetarians, especially vegans who've been vegans for long. They actually end up having vitamin B12 deficiency, so they feel very weak. So they can also benefit from B12 injections. And also when you have, what is it called, pernicious anemia, you know? Yes, then you need B12 injections, or usually people who've had previously, there's been a stomach or intestinal surgery like a gastric bypass, or the diseases affecting the small intestines like Crohn's disease or celiac disease. But you don't just wake up and go and get an injection. You have to be evaluated and then provided. Like for people who are the vegans, they start to feel very weak, very fatigued, shortness of breath, pale skin, like it's a medical condition, then they have to get it. Yeah. Thank you very much. I just wanted to add to that.
Thank you, Alice.
All right. We have a hand at Choga.
Choga, go ahead.
Okay, good evening. My question is also on B12. I heard you said if you are taking metformin, you're likely it disturbs. Did you say it disturbs the digestion of B12?
Absorption.
What did you say?
Absorption.
Absorption, yes, of B12. So what's the recommendation? Are we supposed to take metformin together with vitamin B12 supplements, or?
That's where now the injection helps. Okay.
But you said I can't. You said I can't just walk in and ask for that injection. So it means I have to wait until I have a vitamin B12 deficiency.
No. It can be checked. If you're on metformin, you need to check regularly. So as part of your annuals, your physician or your caregiver should be checking for your B12 levels.
Yes.
If you're on metformin. Yeah, a lot of people forget that. But it's very, very important to check your B12 levels, because it doesn't totally eliminate the absorption, but it reduces the absorption.
Okay. Thank you.
Yeah. Okay. We had the other client who was asking questions before we started the session. Mr.
Yes.
Gola.
Oh, yes.
Were you answered? Are you happy?
And probably in the line of what Mr. Gola was asking, I could just elaborate a few things. Drugs such as sulfonylureas, when you're taking them, take them before meals, okay? Before, half an hour before your food. Now, before you swallow the drug, make sure the food is ready. Don't hear that, oh, the food is halfway. Halfway could mean 1 hour, it could mean 45 minutes. So the food needs to be ready. So sulfonylureas, when you're taking things like Downil, Amaryl, except for diamicron. Diamicron MR can be taken just before you eat, okay? Because of its action profile. It's a modified release. So those dynamics don't work for it. But most of the drugs that you're going to take that are sulfonylurea, your Downil, your glibenclamide, Amaryl, they Nogluc, they need to be taken half an hour before you eat. Glucophage must be taken with food. If you're taking Arcabos with food, those drugs, Arcabos and glucophage, you do not want to expose them, your stomach, expose your stomach to them. So you don't want to take it on an empty stomach or sometimes after food. It must mix with your food for maximum effect. And then secondly, when it mixes with your food, it reduces the side effects. So the bloating, the gassiness, you know, the colic that you feel when you take it after food or before food is there. So those are some of the critical things with your medication. So Ogola, if you can comment whether whether that was helpful for you or not.
Thank you very much. It's more than helpful, but I'm still learning. Like I didn't know that metformin reduces vitamin B12. I have also intestine issues. Since before and even after taking, I used to have on and off intestine issues. Now, when I'm taking this glutamate, it has increased. I was told that my brother-in-law is a doctor, so he told me it will just be for a short while, but the short while seems to be taking long.
Yeah. What you can do now is try and take it with food and see the difference. If it doesn't work, which brand are you using? What's the name of the brand you're using?
It's called, let me read everything for you. It's made in Kenya. Something by Square Limited. Something Square Limited. Okay. It's called Glutamate 50 over 1,000, made by
yeah. So you can
PPZ at River Machakos.
Yeah, so what you can do sometimes, what we notice sometimes with the glucophage, the brands also have less side effect, okay? So what you can ask your clinician is to change the brand and you see, but what you can try even with this one, first try taking it with the food and see if there's a difference. If there's no difference, then they can try a change of brand. And if that still doesn't help, then it would be advisable then to try and use something that you're comfortable with. Because when you're not comfortable with the drug, it's causing you side effects that make you uncomfortable, then your adherence can start being a problem. Nobody wants to take every day.
The side effects are that bad feeling and how do you call it? I can say the loose stool. But on a positive note, I used to go to the urinal at night 4 to 5 times. Now that one, it has eliminated it, kabisa, on a positive note.
Yes.
And I used to have eye problems. It has eliminated it at least 90%. So what I fear is if I change the brand and then I find that brand, afadhali, because I was told this brand is the best, but I don't. What I was wondering is if I can reduce. You call it titrating. If I can reduce the taking, like when I don't take it, I feel better. When I take it only once a day.
Now the thing is, these things of saying the best.
Hello.
Those things of labeling drugs the best, that this, they're relative. Let me just tell you, they're relative. Yeah, you may find that you try something else and you'll find it just works fine. Yeah. Okay. So we probably can take this off the whatever during the week and discuss this further and see how we can assist you to be able to negotiate with your caregiver for a possible change. Okay.
Okay, but I'm on the way of, I'm nearly finishing. This is the second week. The first packet ended after 2 weeks. Now this is the second week. This one is nearly ending.
Okay.
And it has made some changes from 20 point something to 7.4, I think. I don't know which medical terms to use, but there have been great changes despite the side
change,
effects.
yeah.
And the weight also, I've lost some weight. So I don't know whether it will. Now, today, I've started feeling pain in my knee, although I have arthritis, not arthritis, uric acid problems.
Yeah, you need a session with Dr. Jalang'o and the dietitian. So maybe like Dr. Jalang'o says, we can take it out of here. But thank you so much for your questions. Yeah. Yes. So thank you. And remember, you have to watch week 1 to week 4. We're in week 5. So you have to learn about glucose management because like you asked the question, how do you reduce? You remember we showed data for one of our clients who was in season 10 or 11. And the way she reduced is she went with that data to the doctor, And the doctor, Lydia, what were you saying? The doctor refused. She's not the one who kept it, but she's the one who kept the data. And so there's no way. So the doctor will work with you to reduce your medication. If you don't have data, what are they working with? So you need to learn to monitor your blood sugar. And then you will see, because when the medication starts, when you change your diet and you start getting low blood sugar, then you have to change your medication, and not you and not us. You have to go to your doctor, to change your medication. And sometimes also when we are diagnosed with a condition.
Sorry. I've also been having headaches when taking this drug.
Yeah. Hydration status. So you need to measure your blood sugar. So we'll send you a chart. Okay, and please watch one of those sessions. I know you came in today for the first time. There's a lot at the back. There's a lot you have missed. So you be up to date, and then we take it from there. There's a question in the chat, Dr. Jalang'o. Let me find it.
That one. How do we manage patients with many comorbidities like diabetes, hypertension, kidney disease, and malnutrition? Wow. That one is a lot. A number of people will be involved in your care. You need a care team.
A team, yes.
Yeah. You need a team to manage you, and it will involve lifestyle will still be part of it. Okay. And very, very critical nutrition. Very, very important. You have malnutrition. I don't know whether nutrition is involved. When you have kidney problems, especially, you cannot afford not to see a nutritionist. Okay. So there has to be a delicate balance for your antihypertensives, okay, in regard of your kidney disease, okay, and then also there is also it's also very, very important to take care of your blood glucose levels, because problems with the kidney disease are worsened when the diabetes and hypertension are not in control. So those are very important. So it will involve a multidisciplinary team. It will involve a number of medications. And depending on the stage of the renal disease, it can be just nutritional management with drugs and lifestyle, or at the very end, you require alternative therapy to support renal function, and that means dialysis, okay? Or at the far end, transplant, okay? So we've had some people who've had transplantation. There are quite a number now in Kenya. But if you manage well, you can even delay. If you are not already a transplant candidate, you can still manage fairly well with good nutrition and have favorable outcomes that reduce your morbidity, reduce your sickness, so that you're not admitted often. Yeah.
Yeah. Thank you for that question, Viola. But yeah, I mean, I guess for me over the years, 29, 20, I've been saying 27 for I think 3 years. I think now it's 30 years of practice. In fact, I like patients like that. I like a challenge, So they will be managed. And already when somebody is diabetic and they have a kidney function and maybe the glomerular filtration rate is very low, most likely they'll be put on insulin, And even if they're not on insulin, I'll talk to the doctor. Why don't we start with insulin to manage these sugars? And then let's manage their diet, get them to a lifestyle that's comfortable, and then titrate the sugars going down. So it is very manageable, but lifestyle targets everything. Remember, when you're diabetic, you take diabetic medication. When you're hypertensive, you take hypertensive medication. When you have a kidney disease, kidney medication. But lifestyle, the natural doctors we talked about, your diet, things like not eating animal protein at night so you can sleep better, it's a lifestyle that applies across the board. Eating more food in the morning, a lifestyle that applies across the board. Drinking water, lifestyle. Exercise, lifestyle. When you do that, one lifestyle will target all those things. You don't need different lifestyles for different conditions. It's the same. Yeah. Dr. Jalang'o, there's a question here. I hope we answered you. And somebody's hand was up. Please don't get tired. We are coming to you. I remember it's Joyce.
Which one is that? I didn't see.
There's one from Abby. I'm trying to portion, but because I'm taking dimicron, my weight has increased.
She's trying
something about that. She's trying to reduce her portion, but because she's on dimicron, my weight has increased. Yeah.
Now, if you, thank you very much for that. Now, if you are on dimicron and you're gaining weight and you're managing your portions, then I start asking, do you may need that dimicron dose reduced? And it would have been nice to know whether you are on 60 or 90 MR or 30. Because if you are on the higher doses, we need to bring it down. And if you are on 30 milligrams, then we probably could try something else, maybe metformin or another, or something like a gliptin, So you need a review and urgently before you put on too many kilos.
Yeah. And this is why I like that topic on hypo and hyper. What I've seen over the years, and that you can say add onto that, is people fear hypoglycemia. So when you have low blood sugars, instead of going to the doctor to understand why my sugars are low, you end up eating. And so you increase your food intake because you're getting hypo. So maybe you take your medication in the morning, lunchtime, you're getting hypos, or maybe 3. So you eat at 3. And so it becomes a new habit because you're always getting hypos and you're eating. When you're getting hypos, it is something that you need to change. Like the minute you change from taking one carbohydrate is a meal, you get hypoglycemia. And that's because your food has dropped, you're exercising, your dosage needs to go down. So we need to stop treating hypoglycemia with meals. That particular day, the first time it occurs, you have to take it, but you need to go to the doctor. And this is why we're encouraging you to keep your glucose readings. It really helps you when you need to talk to the doctor. So, Abby, you need to call Dr. Jalang'o and you need to call us. We're here. We're on the group. You're not sending
we'll guide you what to do.
But I know you even tried you took blood sugars and shared with me. Very good. So please call. We're here to support you. Yeah.
Okay. I was checking to see how many it is. 60 mg.
Yes, she's on 60 mg.
60 mg, yeah. That can be reduced to 30. So you need to talk to your clinician, but back it up with evidence. Don't go talking. Nobody's going to bring it down without blood glucose reading. So what you need over the next week, maybe even 2 weeks, take your blood glucose readings. And then from there, you go with that, and then it will be easier. Otherwise, you're going to gain a lot of weight.
Because your dosage is high, and since you've already changed your lifestyle, you've already reduced your carbohydrates, you've reduced your portion, the medication needs to be reduced, you know. But I don't think she can wait for 2 weeks. She can go talk to, I think she has been keeping some readings. Just go and explain. You see the goodness with doctors. If you know your stuff, they're not going to argue. Daktari, this is how I used to eat. You have your food pictures. This is how I used to eat. This is how I'm eating. My medication, my dosages, my sugars have dropped. I feel like now I'm gaining weight because of this. So he will understand, you know. But keep your sugars. Well done, you know. So Joyce, go for it. Was it Joyce that the hand was up?
Yes.
Yes.
Please go ahead.
Yeah, first and foremost, I want to appreciate so much the learning that I'm getting here.
Thank
you. Has really helped me.
Thank you. Glad to hear that.
The only problem I have got a very poor diet. And because of the pain I've been going through, I have got a sciatic nerve, which is releasing a lot of pain. Even walking is a problem. So that is one. And although this is something which came recently, I've had insulin for many years. I started with the humulin lentil. And then after that, my blood sugar went on honeymoon. I wish I had met you people. You could have helped me to know how to cope with that. Then after some time, the sugars came back again. I was put on Amaryl. A very minimal dose. In fact, I was taking half a tablet.
That was how many milligrams?
I think it must have been 1.
Okay.
Because I was seeing this Dr. Eva Jenga then, and she was telling me that my medication should be walking, and my diet. So after some time, and I came to know when the body is under stress, the sugars come back. So then that is when now I went back to a doctor, the diabetic doctor, who put me on Novapen. And this I took for quite some time. So recently I changed the doctor, one who is helping even with the diet. He put me on Amaryl 2 units and Epafro. I don't know, 10.
Empagliflozin. Empagliflozin?
They call it Empaflo.
I think, did you give your drug on the list? I saw something like that.
Yes, I did.
Yeah, that's empagliflozin. That is an SGLT2 inhibitor, the one which makes you secrete sugar, not allow the kidney to reabsorb it.
Okay.
It reduces your blood glucose as well.
It's 10/5 milligrams. And then mixed. I'm taking, he's changed, he said Novapen, he likes giving his patients mixed because he says it works better. And actually what I've seen, I'm going back to see the doctor on 20th because I've been having very low sugars in the morning.
Good.
That is something that I'm looking forward to. Then what I've learned, that these drugs, I should take them half an hour before food. That's something that I'm learning, and I'm looking forward to learn more about this.
Yeah. So if I could just reemphasize, the ones you take half an hour before food are the sulfonylureas, your diamicron, your downil, your glibenclamide. The other one is your insulins, the human insulin. Okay. If you're using an analog insulin, you take just before food. So Mixtard can be taken half an hour before food because it's a human insulin. It's not an analog of human insulin. So yeah, that's fine.
How about this Empaflo?
Empaflo just after food.
Oh, after food.
Yeah, just after food. Yeah.
And Amaryl?
Amaryl is What's Amaryl? Which group? Sulfonylureas. The sulfonylureas half an hour before.
I need. I have
Yes,
got.
you check. Yeah, sulfonylureas, Amaryl, Amaryl, diamicron. Unless you're taking diamicron MR. If you're taking diamicron MR, that one you can just take before food, just before you eat. Yeah.
Diamicron is also Amaryl.
It's not Amaryl, it's a sulfonylurea. They are two different drugs, but within the same group, working at the same point in the pancreas. Okay?
No, I don't. I take 3. I take Amaryl, Enfamflo, and Mixad.
Yeah, so Mixad is taken half an hour before. Amaryl is taken half an hour before. Empaflo can be taken after your meal.
Okay.
Immediately after your meal.
Okay.
Okay.
Thank you very much for this information.
You're welcome.
And I'm looking forward to more.
Yeah, what
so
I'll
we
do
watch
as I
and
put
we
the
watch.
drugs on the chart, when I put the drugs on the chart, I'll put a small sentence how it works and when to take them, so that once you see your group, you're the group where your drug is, you also are aware how to take it. Okay, so that will help as a reminder. Yeah.
Okay.
Yeah. Yeah. So you need to know your drugs. The more you know, the longer you live and the better you have control. Yes. So I think we've exhausted the questions on the group. Kindly explain the okay. Yep. No more
Lydia,
questions.
unless there are any other questions from the other sides.
Yeah, I thought that we would have two topics. It's not possible with this. So well done, guys. Your participation has been very good. Yep.
Very interactive.
Yeah.
Yep.
Right. So if we've exhausted on the questions, we still have the group. If you think about a question, post it there. Our doctors will answer. Yes. But thank you. Thank you so much. Thank you so much, Ms. Jalang'o, for that informative and practical presentation. We truly appreciate the time that you've taken to simplify what can often seem very complicated for us. Understanding the medication you take is one of the first and most important steps in taking control of your diabetes and any other health condition you may have. So thank you once again, Ms. Jalang'o. Our final session this evening on planning ideal meals and grocery shopping, we'll have to move it to next week due to some time constraints. So please stay tuned. Next week, we actually have a treat. We'll have a documentary to review. Please note the title of the documentary, Hack Your Health. Watch it in advance. We shall have a whole discussion about it. Tomorrow, we'll share this week's challenge. Please, we encourage you, take a few minutes to complete the assignment. It could be more important than you think. Some past DTLC participants have actually discovered that some symptoms they've had for months, for years, were actually side effects of medication they were taking. So simply reading that medication leaflet can help you understand your body. So don't skip this challenge. As we come to the end of today's session, of course, a very special thank you to Ms. Atieno Jalang'o, to Dr. Alice Ojwang, to you, dear participants, for a meaningful discussion that we've had with your various questions. Thank you so much. So today's session reminds us that medication is important, but it is only one part of diabetes management. Lasting results come from medication that is combined with lifestyle changes. I want to leave you with this quote. It's one quote that Dr. Ojwang actually loves. And of course, it's an anonymous quote. It says, taking medication without eating properly is like washing your hands and then drying them in the dirt. It's a simple illustration, but carries a very powerful message. Medication can do its job, but it can do it much better when we support it with lifestyle. Remember, you don't have to be perfect. You just need to be consistent. Thank you. Thank you once again for joining us. We wish you a healthy and a very productive week ahead.